I'm really happy to be here. I'm Dr Caoimhe Hartley. So I'm a GP. I specialise in women's health and in particular in menopause. I run the Menopause Health Clinic. We're based out in Dalkey in County Dublin. And as of yesterday, we've launched our new public menopause service out of the Rotunda Hospital, which is really exciting. And happy World Menopause Day, obviously, to everyone. So today I'm going to give you a talk. We're going to start just going through some basics, and I'm happy to take questions then at the end as well. Okay, so I'm going to have to look over my shoulder for my slides because I don't know it's okay. So I wanted to give you some background because I think we're all aware of women's health and how it's been treated for many years in modern medicine, and the fact that it was largely ignored. It was left out. Women were often left out of many of our research studies for many years, but menopause in particular, I think, has been kind of ignored for a really long time. And there's often this stereotype of, the hysterical menopausal woman, and in fact, even the word hysteria comes from the Greek word for uterus, just to set the scene a little so you know what the starting point is. Thankfully, we've moved on a bit, so we can move on to the next slide. Thanks. So moving on. So what is menopause? So basically, menopause is just the term that we give to our final menstrual period. That's all it is. And you are postmenopausal if you have gone 12 months with no further bleeding. So you don't really know it's your last period until you can look back and know that 12 months has passed. And in the years leading up to that final period, you have normal reproductive life. That's pre-menopause, when periods are regular. And typically what we see during that time is that your ovaries produce an egg once a month. You ovulate. It's usually a 4-week cycle where you have a bleed, and then 28 days later you have another period. And throughout that time, your ovaries are producing different hormones, but in particular estrogen, progesterone, and testosterone. When we get to perimenopause, and on average that's from the age of around 45, we start to see changes in how those hormones are produced. They become a bit more erratic, and ovulation becomes less regular. And then at menopause, it stops. Your estrogen production falls and stops, and your ovulation stops, which is why reproduction and the ability to become pregnant ceases. And we see different symptoms happening at different points throughout these different stages. So that's what menopause is. And basically, as you can see here, it's due to the cessation of ovarian function. So on average, this happens around the age of 50 or 51 in the Western world, but it actually varies across the globe. Typically, we would see symptoms last for about 5 to 7 years. It can happen for lots of different reasons. Some women have an early menopause that happens under the age of 45. So your periods stop under the age of 45. That's about 5% of the population. And then we have premature menopause, which is under the age of 40. And that's about 1% of the population. Typically, what dictates when your periods are going to stop, it's actually genetics more than anything else. Other things like smoking, how many pregnancies you've had, other lifestyle factors, how active you are, how much alcohol you drink may play a part in that, but predominantly it's actually genetics. But we can also put someone into menopause. So if you have your ovaries removed, we're taking away what's producing your estrogen, and you're automatically put into what's called a surgical menopause. And that's often a lot more abrupt, it's more symptomatic, so people often feel much worse when they go through menopause that way. But chemotherapy, radiotherapy, other medical interventions, some medication even can induce menopause, can stop your ovaries from working properly. Okay, well, how is it diagnosed? So I get asked about this a huge amount. Do I need blood tests? How do I know if I'm menopausal? How do I know if I'm postmenopausal? And to be honest, most of what's guiding us is actually just how you are. It's your it's your story. So if your periods have stopped and you're 12 months now with no period and you're over the age of 45, we assume that's because your ovaries have stopped functioning and this is just normal menopause. Women under 45, though, will often check that by doing blood work. And we expect if your periods have stopped completely, there's a level, I think, called an FSH level, little hormone from your brain. We expect that to be very high if you're menopausal. And so we check that with bloods. However, we do blood work sometimes just to rule out other things that can mimic menopause. So things like thyroid disease, anemia, and there's a few other, some rheumatological conditions, lupus, there's other different things like that that may mimic some of those menopausal symptoms, and it's worth ruling them out. But we don't usually use blood work to check your hormone level. It's not really going to change anything. And if you think of women who are still having periods, if they're perimenopausal, they're still having periods, and they're wondering, am I perimenopausal? Have my ovaries changed? Are the symptoms I'm having, are they related to this hormonal change? measuring bloods doesn't give us that answer because the hormones themselves are going up and down in the background. So like, what are we you're measuring something that's moving in the background. So that can be really frustrating. For women, we might actually just go back, Lisa, if you don't mind. No, that's okay. For women, if women who have a Mirena coil, so women who've stopped having periods because of a medication they're on, or who have something like a coil and their periods have stopped, they might find it really difficult to know, like, when have I stopped being perimenopausal and become menopausal? And the answer is, we don't know. So I won't know. If you have a coil in, I won't know when your ovaries have stopped their own production. And in a way, it doesn't matter. So defining that point of time of when you become menopausal is actually irrelevant. If you have a coil in, we don't care when you become menopausal, because I know you're going to become menopausal at some point. And if you're not having symptoms, great. And if you are, we can treat them. But pinning down that point in time actually doesn't really help, doesn't make a difference. Okay, we'll move on. So what to look at or look out for with perimenopause. So I think a lot of women in the last couple of years have learned more, and there's a lot of information out there which is great about menopause, but perimenopause is sort of the sister that nobody wants to talk about. It's just there in the background. A lot of people are familiar maybe with the term but don't know exactly what it means or what it's describing. And basically it's just describing a time of hormonal change that's happening from your ovaries. In terms of symptoms, commonly what we would hear from women is that it's like PMS but much worse. So essentially what you're getting is an overproduction of estrogen at some times, and then at other points an underproduction. So instead of bobbing up and down in this kind of, like small little fluctuations from month to month, it's more of a roller coaster effect. When you're producing too much estrogen, we see breast tenderness, we see headache, we see heavy bleeding as well, which can be a really common thing in perimenopause. And when you're producing too little, well, it's much more common then to get hot flushes and night sweats and those kind of symptoms. But because with perimenopause you're kind of violently going from one extreme to the other, we get a lot of mood symptoms. We go, oh my God, people are nodding, it's awful. It's awful when someone's relating to these horrible symptoms. And a lot of people actually feel worst through perimenopause, I find, because it's just like being strapped into a horrible roller coaster. And then at other times you might get a month or two where you feel absolutely fine, and so you totally doubt yourself, going mad, I was imagining it, I'm fine, and then it happens again. One of the ways I think that's helpful to pin down, is this perimenopause or is it not, is to look for some sort of pattern. Often your symptoms are worse the week before your period. So if you see that as a kind of consistent thing that's happening, my symptoms tend to be at their worst the week before I get my period, and then I feel a bit better actually once I have my period. They're hormonal symptoms more than likely. But just to reiterate, blood work is probably no help at all. Okay. We can move on. Yeah, perfect, thanks. So I've just given a few quotes there because we do see a lot of women in perimenopause coming in genuinely feeling like, I'm so moody, I'm so emotional, am I going crazy? And it can be really difficult to help someone tease out what's affecting them in terms of other stressors in their life, like work stress and home stress and financial stress and COVID stress, and what's hormonal. Often we can't ever separate those two things out because it's just impossible. And it's just a big melting pot of, well, stress, I suppose, at the end of the day, but worsened by this hormonal change in the background. Okay. So just in case I haven't got the point rammed down your throat enough, there's a roller coaster behind me, because it really is a horrible up and down sensation, I think, when it comes to perimenopause. But yeah, I think getting your head around, look, it's not hormone deficiency. Menopause, where you stop producing estrogen, and we see hot flushes and night sweats and vaginal dryness, and that's much more to do with not producing estrogen anymore. Perimenopause, you're overproducing it at times and underproducing it at other times. Okay, thanks. Okay, so going back to menopause, just the classic symptoms and signs, and I think everyone at this point is pretty familiar with the idea of hot flushes and night sweats, and that these happen, and they're very common. About 70 or 80% of women are going to experience hot flushes or night sweats at some point. They're very disruptive to sleep. They can be desperately uncomfortable. There's a range. Some people find, I might get them once a week, and I have other women who are literally every half an hour having to take their clothes off and put them back on, and they're awake all night, putting the bed sheets on and off all night, and everything in between. So it's a hugely individual experience, I think, and how bad your symptoms are, again, seems to be very variable and very individual. But hot flushes are probably one of the more common symptoms. Obviously a change in your period, so that's, kind of goes without saying that you'll either see an irregular pattern, they can be more frequent, or at menopause, obviously they stop. Or they might get heavier. So often in perimenopause, we see heavy bleeding. So other symptoms, just the kind of lesser known symptoms. I'm often wary about putting this up because I feel it frightens the bejesus out of people when you see this like list of things. I think it's important to note that most people don't get all of the symptoms on the screen, thankfully. I mean, some do, but most don't. And that it does seem to be very individual. For some women, it's very physical. It's all hot flushes and night sweats and joint aches and pains. And for others, it's all mood and emotional symptoms. You're about 2 to 3 times more likely to develop depression and anxiety through the menopausal transition than at any other point in your life. And women who've had postnatal depression, women who have a history of depression or anxiety in the past, they're at much more risk of having issues with depression and anxiety as they go through this hormonal transition. So worth maybe just noting that in the back of your head, that it's a risk factor. And for others, yeah, we see burning tongue, we see changes in hair, changes in skin. There's a thing called formication with an M, formication, where you get like a crawling sensation on your skin, which can be very unpleasant. Palpitations are hugely common as well. Most women will end up with their GP. They've maybe been checked out for that, and by the time they come to see me, they've had their ECG, they've had things checked out. There's no explanation for their palpitations, but they're actually part of the vascular changes we see happening as part of hot flushes and night sweats, which is interesting. Okay. That list goes on, unfortunately, but and so that's okay. But just in terms of hot flushes, because they are so common, I thought it was good to maybe dedicate one slide to them. So on average, they last about 5 to 7 years. They often start before your periods stop. Yeah, I can see the, that got a great reaction, that particular piece of information. So they do go on for much longer than we sort of think they do. Or I think in popular culture, there's this thing of like, oh, it lasts a year and you're there with your like that's not it at all, actually. And they're very different, like from talking to women all day long about this. For some women, they are that almost cartoonish, you know, I feel the heat rising and then I'm sweating and I'm stripping off. For others, it's actually not a flush. It's just a really horrible sensation of heat or warmth. And it's accompanied by anxiety and almost this feeling of wanting to crawl out of your body for a few minutes and get back in. And that's a really difficult thing to treat. You can't just cool down. It's not as simple as that. But why are they happening? So we don't really know, being perfectly honest, but the theory is that your hypothalamus, which is at the back of your brain, contains essentially your thermostat. And for some reason, when your estrogen levels start to fluctuate and ultimately fall, and maybe because of some changes in other hormones in your brain, other neurochemical hormones as well, that thermostat, its range of your core body temperature where it's happy narrows. I think you can kind of see it on the top versus the bottom. So instead of your hypothalamus, instead of your thermostat being happy with you living in a certain range, it decides it's only happy in this really narrow range. And as soon as you wander, as your core body temperature wanders outside of that range at all, it tries to correct your core body temperature. And typically, it's that it thinks you are too hot, ironically, and so it tries to cool you down by bringing all your blood vessels to the surface. It makes you sweat, but it's inappropriate. You're not too hot, so you get this horrible sensation, and then you're too cold. So most women who do get that physical sensation of sweating and flushing are then freezing afterwards. So that's a joy, as you can imagine, going from one extreme to the other all day long. And at nighttime, incredibly disruptive to sleep because you just can't get comfortable. And I know Penny's have brought out, there's like menopause clothes, and I don't know how useful any of that stuff is, to be perfectly honest, but I have other good treatments, thankfully, coming down the line. Okay, we'll continue on. I'll just mention actually hot flushes. So women who get more frequent hot flushes, more frequent night sweats, number one, we think they're at higher risk of cardiovascular disease because this is a vascular thing that's happening in their body. And number two, it tends to be associated with more reporting of cognitive symptoms. So that's one thing I should have mentioned earlier, brain fog, what a lot of patients call brain fog. So these changes in how your brain is functioning are really real. Just to validate anyone in the room who's thinking, I have this symptom, it's not in your head. And typically, it's actually verbal changes. So it's changes in finding verbal fluency, ironic now, I can't think of the word, but it's finding the right word at the right time, thinking of someone's name, and learning new information actually can be really challenging. So short-term memory, they're what are reported the most often. The worse your hot flushes and night sweats are, we think the worse your brain fog tends to be. Those two things seem to coincide. They've done all sorts of research on this, and they've removed they've kind of categorically shown that it's not age dependent. A lot of women, I think, get terrified as these changes in their brain function happen, or their cognitive function. They feel like they're developing dementia if you're on the more severe end of the spectrum, which is about 1/5 of women. Like, it's not a small amount. And they'll come in genuinely upset, like, I'm worried that I'm developing dementia, I can't function. Is this it for the rest of my life? Is this my brain aging? So it's not, is the answer. There was studies looking at this in the States where they've shown on PET scanning, if you put somebody through a PET scanner and you image their brain in their 50s, going through a natural menopause, you actually see changes that are reliably linked up. They're associated with drops in estrogen. So you can say this person's estrogen level is X amount and her brain scan looks like this. And everybody else who has a similarly low estrogen level will have similar changes on her brain scan. But if you take a 30-year-old who has her ovaries removed, her brain scan will look the same. It'll look the same as the 50-year-old who's gone through menopause naturally. So it's not an aging thing, it is a genuine hormonal effect. Why did I talk about that? Oh yeah, because hot flushes make that worse. Mood and emotional symptoms, I kind of touched on this earlier, but really important to acknowledge it because it's so common. And it's probably one of the more impactful symptoms. In some ways, if your hot flushes and night sweats are not too severe, you can kind of work around them a little if you have to. Whereas, if you develop very bad anxiety, that's there all of the time. And it has sort of far-reaching, it can impact on your work, your relationships, but your ability to just enjoy things on a day-to-day basis. So it's really important to note that that's really common and you're not alone if you're feeling those symptoms. Okay, we'll drive on. Thank you. So I throw this in nice and early. And I love that we have a couple of men in the room, which is great. But so vaginal change is really common. Again, probably about 80% of women, if not more, like it's almost universal. But on a spectrum, some people more severe than others. Those drops that fall in estrogen really changes the integrity of the skin, the vulvar skin on the outside. It changes the elasticity of the vaginal canal. So instead of having, you can see here on the left, they're called rugae, you have almost like folds inside the vaginal canal. And they allow for stretch. It's like a concertina effect. And with that loss of estrogen, that tissue inside the vaginal canal thins and flattens out. So with any friction, or which can be intercourse, but also just even inserting a tampon, there's no give in that tissue anymore. So we see tearing, we see pain, we see discomfort. There's a change in lubrication, and so we see vaginal dryness quite frequently, painful intercourse. The pH of your vaginal environment changes with this drop in estrogen, and that encourages the growth of bacteria that actually don't normally colonize there when you're younger. And that leads to recurrent urine infections because bacteria love living in an environment with a high pH, which is what happens when you lose estrogen. And the bacteria that love that environment are also the bacteria that like climbing up the urethra and infecting your bladder. So it's one of the reasons we see more common urine infections. This is the most treatable. No one should have vaginal symptoms postmenopausally. Nobody. It's so treatable. We have hormonal options, non-hormonal options. They're really safe. If you've any symptom like this, you should talk to someone. It is one of the symptoms that doesn't get better. So hot flushes, I know they terrified everyone by saying 5 to 7 years, but at least there is an end point for most women. Cognitive changes are transient. Most women, their brain fog will improve with time. It might take 7 years, but it will improve with time. Vaginal changes will get worse for the rest of your life. So your tissue never adapts in that part of your body. So treating that is really important. And it's obviously easier to prevent it getting worse than try to treat it when it's got really bad. Okay, thanks. Heavy bleeding, so please don't ignore this. Really common in perimenopause, really treatable. It always amazes me the amount of women that we have coming into the clinic who will say their bleeding is actually so bad that they are missing work, or they have to carry 2 spare changes of clothes with them a couple of days per month, and just accept that as normal because that's what they've been told. It's not normal if it's impacting you to that degree, and there's lots that we can do about it. Okay, we'll move on. I'll speed up a bit. So lots of options, thankfully. I'll just touch on this very briefly. It's really important. I think this is really intuitive. I think people know why menopause should be important in the workplace because, women at this point in their career are actually holding up most of society between work and, in schools and in education and every facet really. And I think, you know, we know from research that came out actually earlier this year that a lot of women consider leaving their job if their symptoms are really severe. Again, that's about 1/5 of women. It's not a small number. And so they need to have good options and good support, and again, really important. Okay, we'll move on. Same idea, it's taboo. You could do a whole presentation on this alone, I think. My personal take on this is that it's this horrible negative attitude to aging, and how we are told from a really young age that everything about aging is wrong and bad and you should fight it, and we should be dyeing our greys and you should be doing everything else to resist aging at all costs. And I think that feeds into an awful lot of why people don't want to talk about menopause, because we link it with aging in our head. There's a grief and a loss associated with that loss of reproduction, I think, as well. And there's, you know, accepting that things are changing into a different part of your life. There's a fear of being treated differently. I mean, there's just this myriad of reasons why people don't want to talk about menopause. For a long time, just from a medical perspective, doctors didn't want to talk about menopause because we didn't have anything to help you. And so there was almost a kind of, you know, like put the head down and forget that it was happening, because we couldn't give women decent solutions for these symptoms they were having. But thankfully that has changed. Interestingly, actually, if you look globally, there are cultures that really embrace aging in other parts of the world, and it isn't seen as this completely negative thing. And in those cultures, women report fewer menopausal symptoms. The menopausal transition is actually easier. They might still be symptomatic, but I think they probably weather it and navigate it better than we do. So hopefully big cultural change is happening down the line. So I've talked about symptoms, but just to note, there are health changes that happen with this loss of estrogen too. So when your estrogen falls and ultimately disappears, we see two kind of principal changes in our health. One is in our bone health. So we see a fairly significant loss of bone density. Estrogen is like a foreman woman, controlling the balance between how we make new bone, because our bone is constantly turning over, and how much we're breaking down old bone. So if you think of two people like on either side of a wall building it up, and then one person is dismantling it, that happens throughout your life. It's bone turnover. And estrogen is one of the hormones that dictates the speed at which this happens. And when you lose estrogen, the person who's breaking the wall down starts to work much faster than the person who's making new bone. And that's why we see a loss of about 2% per year of our bone density for those first 5 years after your periods stop. So this ultimately can lead to osteoporosis, which is not uncommon. It's probably about half of women over the age of 55 will have some significant bone density loss. And osteoporosis, or brittle bone disease, is not just, I mean, I think we associate it commonly with hip fracture, and I think that's kind of, you know, what people classically think of it with, but actually chronic pain, immobility, a loss of your independence, you know, as you get older, a loss of being mobile normally. There's other knock-on factors that happen, so it's actually a fairly big public health issue that we need to address. And we know that with estrogen replacement, which we'll come to in a sec, we really slow down that bone density loss. The other thing that's impacted on here behind me is your heart. So your blood vessels start to change. When you lose estrogen, your vessels lose their flexibility. They start to become a lot more rigid. And that really promotes the formation of plaque and a buildup of obstruction or blockages in your arteries and your blood vessels. And that's the beginning of kind of laying that foundation for developing heart disease or stroke ultimately. And that is a normal part of aging. But if you look at younger women who have menopause early, they go through those changes like an older woman would. So there's definitely an association here with that loss of estrogen. And that's why it's important. So just to reiterate, we see changes in blood vessels, blood pressure, cholesterol. Okay, controversially, I've thrown in Alzheimer's dementia. So women are about twice as likely to develop Alzheimer's compared to men, unfortunately. And this is a new area of research in terms of hormones, and we think that estrogen probably has a role to play in that. The current thinking, just to clarify, because there's a lot of misinformation about Alzheimer's and HRT and menopause out there, but the current thinking is that in perimenopause, so when you are still having periods but your hormonal production has changed, we start to lay down proteins in our brain called amyloid plaques, and that's a risk factor for developing Alzheimer's dementia. What we do not know is if we intervene and give somebody estrogen at that point, will that stop them from getting dementia? We don't know that yet, and anyone who tells you otherwise is not evidence-based. But we have a suspicion that that might be the case, but we can't back that up with research just yet. and this is, yeah, kind of going through we won't skip over this. So essentially just estrogen, very important for your brain, is the kind of take home message. Okay, but moving on to options. So having terrified you with all the horrible things that happen through menopause and how awful everybody feels, which is not true, obviously, but you know, it's nice to look at, well, what can I actually do? What are my options to feel better and to protect my long-term health? So loads of options, thankfully. But I start everybody with just talking about lifestyle. And nobody loves me for this, but I suppose we, you know, like we do discuss limiting alcohol and reducing caffeine and looking at increasing exercise. And I often feel like a complete hypocrite for most of the consultation, sitting there with the caffeine in hand, knowing I haven't done any exercise myself in months. But it's all stuff you know, basically, you know, and a healthy Mediterranean diet, monitoring your blood pressure, your cholesterol, being active, all of those things you kind of know you should be doing and shouldn't be doing, they're all really true at the time of menopause. Whether they impact your hot flushes or night sweats or other symptoms, I don't know, it's hugely individual, but certainly they don't hurt your long-term health, so there's something to look at. Cognitive behavioral therapy, CBT, really helpful for anxiety, low mood, that loss of confidence actually that can happen, that negative narrative that creeps in often at the time of menopause. CBT is actually really helpful for that. It's not a prescription, you know, it's something, and there's a really good free online CBT program that you can ask to be referred to through your GP. It's called Silver Cloud, because CBT can be very expensive depending where you go. So all of those things are really helpful. We have really good non-hormonal treatments. So, you know, you'll hear often through the media or through Davina McCall's documentary or different things, people talk about being offered antidepressants by their GP. So obviously not our first line, and it shouldn't be the first thing that we go to. It's not the most effective thing for treating menopausal symptoms. But there is a role for antidepressants. If you are clinically depressed or have generalized anxiety disorder, then it might be first line for you. If you're someone who can't take hormones because you've had breast cancer, for example, well, then it might be a good option. But they have an impact on hot flushes and night sweats. So for women who choose not to go down a hormonal route, we have very good alternative options. So we do use antidepressants at times. There's a couple of other medications, a medication called gabapentin, which is actually an old-fashioned anti-epilepsy, anti-seizure medication. We use clonidine, which is a blood pressure medication. I say we use, it's actually useless, but nobody uses it, but every guideline you read will have it in it. And there's a couple of other medications that are very effective for reducing hot flushes and night sweats. So it's not all about HRT. However, HRT is the most effective, so we might move on to that. So hormone replacement therapy is a combination of estrogen and progestin, or estrogen, progestin, and testosterone. So if you think of what your ovaries produce, they produce all of these three hormones. And that's what we're essentially trying to replace, or the replacement might be the wrong word, because in perimenopause you can still take HRT. If you're still having periods, hormone therapy will help. We're not really replacing anything because you're still producing estrogen, but we're trying to get that roller coaster to settle back down into something that's a bit more livable with, and we achieve that often with HRT. So estrogen is the kind of backbone of all of this. It is the bit that makes your hot flushes and night sweats hopefully go away. It's the bit that makes most of you feel better. It's the bit that gives most of your symptomatic improvement. It's also the hormone that reduces bone density loss, and if it's started at the right time, so under the age of 60 and within 10 years of your last period, we'll actually see a reduction in heart disease. And again, as I say, its influence on the development of dementia is kind of unknown at this point, but there may be something positive there, we're not sure. So that's your estrogen. So basically everybody ends up on estrogen pretty much. Why we give someone progestin, this other hormone, depends on whether or not you've had a hysterectomy. So estrogen will encourage the lining of your womb to thicken and grow. That can lead to womb cancer, which obviously we do not want. If we give someone progestin, we don't see that happen. So progestin's role is to protect the lining of your womb. Testosterone is a whole other thing unto itself. Not everybody needs it. It can be used for low libido. I'm sure I'll probably get a couple of questions about testosterone at the end of this, and we can go through it in more detail then if you want. But basically it's, you know, everyone gets estrogen, some people get progestin, and in the odd circumstance we might give testosterone as well. Okay. Different ways of taking these combinations. Actually, if we go to the next slide, if you don't mind, Lisa, because I think I give some. So typically, estrogen can be taken by mouth, so it's a tablet, as I suppose we take most of our medications that way, but interestingly, we can also give estrogen through our skin. And that was one of the things that's really changed how we give HRT and changed the risks associated with it. So there's the patch. I don't know why I'm pointing to my arm, sorry. It goes on your back, your bum, or your tummy. There's a patch. There's the estrogen gel that's typically on your arms or your legs. And there's actually a spray, really nifty little device, looks like an inhaler, and it's a once-a-day application. And your skin absorbs the estrogen, and the big difference between oral estrogen by mouth and dermal estrogen through your skin is the risk of blood clots. So we don't see any increase in blood clotting if we're giving you your estrogen through your skin. So it's safe in women who have a history of blood pressure, migraines, or even women who are at higher risk for having a blood clot, who can't take the pill. Well, they can't take oral estrogen, but they can take dermal estrogen, and it basically interacts with nothing. It sort of plays well with everyone. So that's your estrogen. There are different ways of, we might go to the next slide if that's okay, Lisa. There's different ways of giving progestin, and that's where it gets confusing with HRT, because you're talking about two different hormones that we can give in different doses and give different ways, and that's why it's not very uniform. And when we talk about risk, that's why it's so individual. This is from Davina, as you can see. So she's a patch here on the bottom left, her gel up here, that's actually probably testosterone, I think, on the top right, and her patch here on the bottom right. So the Estradiol patches, they're teeny tiny, like they're half the size of your thumb, and they're translucent, so you can't usually see them when they're on, and they're waterproof. Okay, thanks. And that's just more examples of estrogen. So progestogen, you can just see that's my little doggy in the corner asleep in her bowl. There's a reason that picture is there. So progestogen, its main role, we're trying to protect the lining of your womb. Loads of different ways we can give it to somebody, but typically it's either taken as progesterone, which is body identical, so a bit of a buzzword. So body identical just means that it has a chemical structure that is identical to what your ovaries produce. So basically, we have a pill that contains the same type of progestogen that your ovaries make when they make progestogen. And you take that either by mouth or you can insert it vaginally. And that particular type of progestogen is sedative, hence the picture. And a lot of women like it because sleep is such a big issue at menopause. And a lot of the mood changes and cognitive changes, they're from poor sleep. And if we have someone sleeping better, their whole life changes, their quality of life changes. So progesterone, although we're using it to protect your womb, for some women can improve sleep. But for others, they might use a Mirena coil, for example, as the progestogen bit of their HRT to protect their womb. So they have their coil and then they're also putting on their patch of estrogen or whatever suits that particular person. Okay. So that's just reiterating. So you can see here on the two pictures here, we see thickening of the lining of the womb happen if somebody's on estrogen on its own, when we want to see a nice thin lining so that someone isn't at increased risk of womb cancer. The most effective way actually is probably with a Mirena coil, and that has other benefits. It's contraception. Your bleeding is likely to stop if you're perimenopausal, and you don't have to take it every day, and it lasts for 5 years. Okay, thanks. So we'll move on from this, but essentially just to illustrate, if you go back, Premarin, which is old-fashioned oral estrogen, it would have been what was used 20 plus years ago. It was the most commonly prescribed medication in the US in the early 90s. It was everywhere. Everyone wanted to be on it. And then in the early 2000s, when the Women's Health Initiative, that big study that changed everything, when they published their results, we saw a drop of about 70% over the next few years in prescribing of HRT. And to be honest, it didn't recover then. And it was only in the last sort of 10 or 12 years when new reporting about that study came out. That's where we've changed our attitude a little bit, and I suppose we know more about risk, which we'll come to now in a second. So just to reiterate, in terms of benefits, we see symptomatic control, we see bone density improvement, reduction in cardiovascular disease, and you generally feel better in terms of estrogen. However, if we go to the next slide, there are unfortunately some risks, as there are with any medication. So in a nutshell, if you're taking estrogen on its own, because you had a hysterectomy and you don't have a womb, we don't think that has any impact on breast cancer risk. In fact, in the Women's Health Initiative, it lowered breast cancer risk. The problem is if you have a womb, you don't have that option. You have to take progestogen with your estrogen. So the current numbers that we use would be that we see an increase of about 3 to 5 breast cancers per 1,000 women after 5 years of using HRT. And there's different ways of illustrating that. So if we go to the next slide, if you don't mind, Lisa, thanks a million. Yeah, there's just another way of saying it. Essentially, we see less than 1 extra breast cancer per 1,000 women using HRT per year, is the other way of looking at it. Or actually, the British Menopause Society have a brilliant sort of visual for this. So they put this into context. If you look at women who drink a bottle and a bit of wine per week, we would see, I think they quote 5 extra, that's this guy here, 4 from the bottom, just there. We see about 5 extra breast cancers per 1,000 women who drink a bottle and a bit of what, well, it depends what the bit, I suppose, is, but a bottle and a bit of wine per week over 5 years. If you look at having a body mass index greater than 30, if you look at women on the pill, women who smoke, etc. So I'm not denying there is risk, and I am at pains to say to everybody who comes into the clinic, there is risk associated with this. It is offset by benefits for most women, but it's individual. And obviously somebody who has a baseline risk of breast cancer higher than average, so you have a family history, etc., then it becomes more important to try and figure out where that balance of benefit and risk lie. The longer you're on HRT, the more risk there is. And the type of progestin, the thing we're giving you to protect your womb, it dictates a lot of the breast cancer risk as well. And that's why these newer progestins have become more fashionable, because we know they're more breast friendly. And that's why we tend to see lower breast cancer rates than even what this is showing. So there is risk, but you have to put it into perspective. And it's an individual decision about benefit versus risk. And that's, I suppose that's why our appointments are 45 minutes long, is because that's, you know, it takes a bit of counselling and discussion. Okay. So just to summarize, so basically some myths. You can take HRT if you're still having periods. So you can't be too young to take it. We use estrogen through your skin as much as possible. If you have a family history of breast cancer, you can take hormone therapy, but you need to have a proper discussion with someone who can contextualize that risk and help you assess where the risk versus benefit ratio lies. We use what are called body identical hormones. So all of the skin approach with estrogen, your patches, your gel, your spray, they all can contain a modern form of estrogen that is a replica of what your ovaries produce. And we try to use these progestogens that are more breast friendly. You take them for, so I often get asked, how long will I take my HRT for? Like, I don't know. And the reason is you take it for as long as your benefit outweighs your risk, which is useless guidance from the British Menopause Society, because how do you assess that? You can't test for that, you know. But it is a discussion on an annual basis to know if someone is still getting benefit. We do a DEXA, so we do a bone density scan when it's appropriate to help someone decide, do I need to stay on estrogen? Am I really high risk for osteoporosis? So that's a benefit I'm getting from it. Or sometimes you take a break, you do 4 or 5 years, you stop. And if you have no symptoms and your bone density is normal, you don't need to continue HRT. But if you are symptomatic, you should be able to take that for the rest of your life. So it's a very grey individual thing. It's not black and white. Just, you know, in case it's not all about HRT, obviously. They're my little girls, swimming, paddling around in the sea. So look at all the lifestyle things. Look at vitamin D, which I didn't mention, really important for bone density. Adequate calcium in your diet, lots of weight-bearing exercise, caffeine, alcohol, all the things, like I said, you know, you kind of should be or shouldn't be doing. They're all still really important for long-term health. And there are very good non-hormonal options. Vaginal estrogen for everybody, if possible, over the age of 50. We should be posting it out to people. Everyone should be on vaginal estrogen. And cognitive behavioral therapy. And then don't forget about screening, because around this time is when things like mammogram screening kicks in. Every 2 years from 50, your cervical screening should be every 5 years if it's normal. And bone density screening over the age of 60, but younger if you're postmenopausal and have a risk factor for bone density loss. So thank you very much. Thank you for your time. Thanks.
Thank you.